So, what is ischemic heart disease? First of all, what is ischemia? You have to understand the difference between ischemia. You have heard the term about myocardial infarction. Okay. So, what is infarction and what is ischemia? Ischemia means reduced supply of blood to a particular area. That is ischemia. That leads to reduced oxygen supply, and infarction means that is full cut off of blood supply and oxygen supply. That is infarction. Infarction leads to gangrene and necrosis of that part, but not like ischemia. Ischemia means reduced blood supply of a particular part. Okay. So, ischemic heart disease grossly we can divide it into two, that is chronic ischemic heart disease and acute coronary syndrome. This acute coronary syndrome part I will discuss in next class. Today I will discuss about chronic ischemic heart disease, its risk factor and pathophysiology. So, what is ischemic heart disease? This is nothing but actually imbalance between oxygen demand and oxygen supply. So, when demand is more, cardiac muscle demand is more but supply is less. So, what happens? There is imbalance between oxygen demand and oxygen supply due to partially occluded thrombus or due to disrupted atherosclerotic thrombus or eroded coronary artery endothelium. Okay. What is atherosclerosis? I will discuss in details in next class, next few minutes. So, what happens is that there is a reduction in the coronary blood flow and downstream embolization of platelet aggregate and or atherosclerotic debris that lead to severe ischemia and myocardial necrosis. Okay. So, today's topic is risk factor. The major risk factor of ischemic heart disease is atherosclerosis. So, I will discuss in detail about atherosclerosis. So, these things you must know after the class, that is risk factor, pathophysiology of atherosclerosis, to some extent about lipoprotein transport. You already have learned about lipoprotein cycle in biochemistry, I think. Okay. I will discuss only about medicine related part of lipoprotein transport and the drugs of treatment of hyperlipidemia. So, what is atherosclerosis? Atherosclerosis is a condition that is caused by cholesterol buildup and inflammation of the arteries. It is caused by slow buildup of plaque on the inside of arterial wall, that is called plaque. Plaque is made up of fat, cholesterol, lymphocyte and platelet and macrophage aggregate. Plaque is of two types, that is hard and soft plaque that causes arterial wall to thicken, and soft plaque that sometimes rupture that leads to arterial occlusion and ischemia or infarction of myocardial muscle. So, this is a progressive disease and it most commonly occur in muscular arteries of coronary artery, cerebral artery, and sometimes it occurs in aorta, leads to aneurysm of aorta, chronic ischemic heart disease and ischemic encephalopathy. So, what are the risk factors? In nutshell, atherosclerosis is nothing but accumulation of cholesterol in blood vessels. Okay. So, that leads to obstruction of lumen that leads to reduction or complete cut off of myocardial vessels. This can occur in myocardium, this can happen in cerebral vessels or any other vessel. Most commonly occurs in medium and large size arteries like cerebral, coronary and sometimes occurs in mesenteric artery. So, what are the risk factors? Risk factors we can grossly divide it into some major risk factor and minor risk factor. In case of major risk factor, there is some constitutional factor like age, gender, genetic factor, familial, social factor, and some acquired factor like hyperlipidemia, hypertension, diabetes, smoking, and minor risk factor like obesity, physical inactivity, stressful life. So, atherosclerosis like cholesterol buildup in arteries, it is mostly associated with age. That is, atherosclerosis is a age related disease and fully developed atheromatous plaque usually appears after 40 years of age. Okay. Evidence in support comes from high death rate from ischemic heart disease, ISD, that is ischemic heart disease in this age group. Atherosclerosis and ischemic heart disease is more common in female than male, but before 40 years of age it is more common in male than female because of premenopausal age group women having a high level of estrogen and high density of lipoprotein that have both anti-atherogenic potential. That's why before the age of 40 years, ischemic heart disease incidence is more in male than female, but after 40 years, it increases in female population. Okay. So, what are the genetic factors? There are some genetic and hereditary factors that causes high cholesterol level and atherosclerosis formation, especially due to apolipoprotein E, and some gene is there that called LDLR gene mutation. This gene mutation causes familial hypercholesterolemia. Okay. Familial racial factor, some familial predisposition is there, like if someone is suffering from diabetes, hypertension, with a background of family history, they are sometimes be associated with atherosclerosis developed in younger age group of patients. Okay. So, this is the main culprit for developing atherosclerosis, that is hypercholesterolemia, has directly proportional relationship with atherosclerosis and ischemic heart disease. The atherosclerotic plaque contains cholesterol, and cholesterol ester largely derived from the lipoprotein in the blood. So, the disease associated with hyperlipidemia, that is myxedema, diabetes mellitus, nephrotic syndrome, are also associated with atherosclerosis and ischemic heart disease. Okay. Hypertension. Hypertension has a direct correlation with ischemic heart disease because hypertension causes endothelial injury. So, what endothelial injury does? Because of endothelial injury, that leads to cholesterol buildup and atherosclerosis due to leakage of this LDL and macrophage into the endothelial cells. That leads to cholesterol formation. I will discuss in next few minutes. It has been noted that systolic blood pressure over 160 mm of mercury and diastolic blood pressure over 95 mm of mercury, that is 5 times higher risk of developing atherosclerosis than normal population. So, smoking also having a smoker can develop more atherosclerosis than non-smoker patient. So, what are the mechanism? Smoking causes accumulation of carbon monoxide that leads to formation of carboxyhemoglobin, that leads to hypoxia, and sometimes it causes atherosclerosis due to platelet addition, raised endothelial permeability, and sympathetic nervous system stimulation caused by nicotine, that is that found in smoker patient in cigarette or something. Diabetes mellitus. Atherosclerosis develops at an early age in people with both type 1 and type 2 DM. The risk of CVS is high, and foot gangrene develops 100 times more in case of atherosclerotic and ischemic heart disease patient. What are the minor risk factors? There are some minor risk factors like obesity and physical inactivity, stressful life. Higher incidence of atherosclerosis developed in countries primarily because of some environmental influences and physical inactivity and lack of exercise. There has been increased risk. Some infectious, this sometimes comes in MCQ question like what are the virus and bacteria that leads to atherosclerosis. This has been found that herpes virus and chlamydia pneumoniae are directly linked with atherosclerosis formation. Herpes, simplex virus, cytomegalovirus, and bacteria, that is chlamydia pneumoniae. Patient with some genetic disorder like homocystinemia, this is an inborn error of metabolism that have developed atherosclerosis and coronary artery disease. Moderate consumption of alcohol has a slightly beneficial effect by raising the level of HDL cholesterol and by causing vasodilation, but persistent consumption of alcohol in large quantities causes more damage. Okay. So, moderate consumption of alcohol is beneficial, but not like that it persistent consumption of alcohol is harmful. Okay. So, what are the pathogenesis? Before coming to pathogenesis, this any question up to this is clear, na? Risk factor and all. So, risk factor mainly major risk factor. We have divided major risk factor into age, sex, genetic factor and familial factor. Okay, these are constitutional factor, and acquired factor is diabetes, hypertension, smoking and dyslipidemia. Some minor factors there, that is environmental influences, obesity, physical inactivity and some stressful life. So, what are the pathogenesis of atherosclerosis? This will be taught in pathology class, I think, in details, but from medicine point of view, I will discuss some points. So, what are the pathogenesis? Pathogenesis of atherosclerosis involves at first from endothelial injury. How endothelial injury and dysfunction occurs? This endothelial injury occurs due to some shear stress like mechanical stress or any toxin or dyslipidemia and hypertension. From this hypertension, dyslipidemia, mechanical injury causes endothelial injury. Okay. This endothelial injury, after endothelial injury, there are blood cells like monocyte and platelet. This monocyte and platelet aggregate into the subendothelial layer. This injury of dysfunctional endothelial encourage macrophage attachment. Turbulence may be responsible for the striking predilection of lesion for region of disturbed flow, such as the origin of vessel of aorta. Endothelial cells bind LDL when activated. These cells attach monocyte macrophage generate free radicals that oxidize LDL. So, what happens is that there is some endothelial injury due to any causes I have discussed in risk factor. For all these risk factor, there is some endothelial injury. After injury, there is exposure of subendothelial connective tissue. This exposure of subendothelial connective tissue is associated with attachment of platelet and some monocyte. See, platelet and macrophage and endothelial cell release some cytokine and growth factor. This growth factor causes proliferation of smooth muscle cell and deposition of connective tissue component. The inflammatory fibroproliferative response leads to a dense fibrous cap and connective tissue overlying the core of lipid and necrotic disc. This is called atheromatous plaque. This plaque can rupture, forming the substrate on which thrombosis develops. First, see this picture. This is the normal arterial wall. Okay, you all know that arterial wall is constitute of this intima, lamina media and tunica adventitia. And between intima and media there is internal elastic lamina, and between media and adventitia there is external elastic lamina. You all taught in physiology class, I think. So, this is atheromatous plaque actually. How it develops, this is depicted in picture nicely, that is, see, there is a chronic endothelial injury due to hyperlipidemia, hypertension, smoking, homocystinemia, toxin, viruses and immune reaction. This causes injury to endothelium. This injury, see, this green one are platelet, okay, and this blue one are monocyte, okay. When blood cells, this monocyte are in the lumen, this is called monocyte, but after entering the endothelial, subendothelial region, that is intima of the blood vessel, it becomes macrophage, okay. We call it monocyte when it is in the blood vessels, but after it entering into the blood cells, we call it macrophage. So, what happens after entering, see this one, after entering into the subendothelial layer, this is the endothelium, okay, this is the endothelium, these are platelet, this is monocyte that entered into the subendothelial layer. These small yellow dots are LDL cholesterol. After entering into the subendothelial layer, these LDL cholesterols are oxidized by free radical and cytokines. These oxidized LDL are engulfed by these macrophages. Okay. See this one. After entering this oxidized LDL engulfed by the macrophages, this cell we are called foam cell. Now this macrophage has become foam cell. So, see this. After entering into the macrophage, this foam cell, lymphocyte, this lipid debris, this forms the core of a atheromatous plaque, and this is the fibrous cap. This fibrous cap is consist of smooth muscle cell, endothelium, and this core consists of foam cell and lipid debris. Okay, see, this is the same picture I has already discussed. The LDL enters into the subendothelial layer, oxidized by interleukin 1 and the MCP, that is monocyte chemotactic factor, and oxidized LDL enters into the macrophage, becomes foam cell. This foam cell release cytokine. This cytokine and growth factor stimulates the smooth muscle cell of the media that proliferates into the subendothelial layer, forming this atheromatous plaque. This pathogenesis is clear. Any question up to this? The lipoprotein transport you have already taught in biochemistry, I think. Lipoprotein consists of lipid and protein. So, lipid and cholesterol are transported into the bloodstream as a macromolecule, that is called lipoprotein. The protein part of lipoprotein is called apoprotein, and this lipoprotein, mainly there are 6 types of lipoprotein, that is chylomicron remnants, VLDL, that is very low density lipoprotein, high density lipoprotein, and IDL, that is intermediate density lipoprotein. So, how these cholesterol are transported? This is the lipoprotein molecule. This outer part is hydrophilic and this inner part is hydrophobic, consists of phospholipid, unesterified cholesterol, and outer part is consist of non-polar, the inner part core is non-polar and outer part is polar. This is apoprotein. Apoprotein means protein part of the lipoprotein and rest is lipid part. Core is consist of triglyceride and cholesterol ester. So, lipoprotein are transported in 2 ways, that is 2 pathways there. One is exogenous pathway and one is endogenous pathway. So, how exogenous pathway acts? The dietary cholesterol and triglyceride are absorbed from the intestine and transported in the intestinal lymphatic as chylomicron. So, chylomicron pass through the blood capillaries in the adipose tissue and skeletal muscle where the enzyme lipoprotein lipase is located. So, what happens is that cholesterol and triglyceride are transported in the intestine as chylomicron. When this chylomicron reaches the blood muscle and adipose tissue blood vessel, there is an enzyme called lipoprotein lipase. This lipoprotein lipase esterifies this chylomicron and releases fatty acid and glycerol. This fatty acid enters the muscle cell for energy buildup, and after that this chylomicron remains as chylomicron remnant. Okay, this chylomicron remnant enters the liver by LDH receptor. First, you see this picture. This is exogenous pathway. You are intaking dietary fat. This intestine, these fats, triglyceride and cholesterol are transported as chylomicron. This chylomicron, after entering the adipose tissue and muscle blood vessel, in blood vessel there is an enzyme called lipoprotein lipase. This lipoprotein lipase hydrolyzes this chylomicron and releases free fatty acid. Okay, this is exogenous pathway, and in endogenous pathway, liver secretes VLDL. This is very low density lipoprotein. This VLDL, after entering the adipose tissue and muscle cell, same way releases triglyceride and remains as IDL, that is intermediate density lipoprotein. This intermediate density lipoprotein enters the liver by LDL receptor and metabolized as endogenous pathway. Okay, and this LDL cholesterol enters the extrahepatic tissue, becomes HDL by releasing some of triglyceride. So, this is the normal plasma lipid level. In adult male, it is triglyceride normal value is 120, total cholesterol is 200. In adult female, it is 80 and 190. So, what are the functions of lipid, that is lipoprotein? These are not always harmful. These are some function in our body, that is triglyceride, major energy source of the cells. Cholesterol causes cell growth, cell division, membrane repair, steroid hormone production, and lipids are causing vehicle for some fat soluble vitamins. So, what are the lipid lowering drugs? These are grossly divided into four parts, that is statin, fibrate, resin, bile acid binding resin, and some other. Statin. What is statin? Statin is a HMG-CoA reductase inhibitor, that is it inhibits the 3-hydroxy 3-methyl glutaryl CoA reductase this is a main rate limiting enzyme in cholesterol synthesis. HMG-CoA reductase converts HMG-CoA to mevalonic acid. So statin, what does statin? Statin causes inhibition of cholesterol synthesis. So this results in reduction in intracellular level of cholesterol and increase in the hepatic LDL receptor. What is hepatic LDL receptor is that when cholesterol is there is hyperlipidemia in the blood, there is increased expression of hepatic, that is liver LDL receptor. For that LDL from the blood enters the liver by LDL receptor. So what are the statins available in the market? This is simvastatin, atorvastatin, lovastatin, pravastatin, rosuvastatin and fluvastatin. Commonly we use atorvastatin and rosuvastatin. Apart from the cholesterol lowering function, what statin does, this is involved in endothelial, improved endothelial function, reduced vascular inflammation, reduced platelet aggregation. This causes, this has some anti-thrombotic effect and causes stabilization of the atheromatous plaque. Simvastatin and lovastatin are specific reversible inhibitor, but atorvastatin is a long-acting inhibitor of HMG-CoA reductase inhibitor. Atorvastatin are taken by mouth at the bedtime and well absorbed, excreted by the liver. So what are the adverse effects of atorvastatin and other statin? This is well tolerated apart from some gastric intolerance and increase there. Sometimes there will be increased liver enzyme, myositis and rash is a rare complication of statin. So biochemistry part of view. See, this is the same picture. Statin is involved in endothelial function, improve endothelial function. It has some anti-thrombotic action, anti-inflammatory action, antioxidant, vascular protection and plaque stability function. So what are the clinical uses of statin? When we use statin, when there is primary hyperdyslipidemia, that is secondary primary prevention of arterial disease in patient with elevated serum cholesterol and secondary prevention of myocardial infarction and stroke. Next one is fibrate, that is fibric acid derivative. Fibric acid derivative are grossly classified into bezafibrate, ciprofibrate, phenylfibrate, clofibrate and gemfibrozil. How they act? Actually, fibrate are acting by PPAR alpha inhibitor, that is peroxisome polyphyreter activator receptor. This then leads to changes in the expression of gene and reduces stimulates beta oxidation of fatty acid. This by probably reduce the hepatic VLDL production. So what are the adverse effects of fibrate? That is, this sometimes leads to renal failure, myositis, and in alcoholic patient it should be avoided. Clofibrate is associated with gallstone formation. Statin we use in case of hyperlipidemia, when statin is given in full dose but it's not working and still hyperlipidemia persists, then we can add fibric acid derivative like phenylfibrate. Okay. There another class of drug, that is bile acid binding agent. This is cholestyramine, cholestyramine and cholesevelam. These are actually we used when there is increased LDL expression in the receptor of the liver and reduced concentration of the LDL in plasma. Mainly bile acid binding resin are used in case of resistant hypercholesterolemia. When we are using a statin and fibric acid derivative in a combination, but still there is lipid level is more, then we can use this bile acid binding resin. See, this is hypercholesterolemia when statin cannot be used, and heterozygous familial hypercholesterolemia we can use. Unwanted effect, there is some nausea, abdominal bloating and constipation is there. Another class of drug is cholesterol absorption inhibitor. How this acts? This interacts with the cholesterol transporter and inhibits absorption of cholesterol from intestine. So we can use in mixed dyslipidemia, patient with low HDL and risk of atherosclerotic disease. We can combine it with other statin and fibrin. Another class of drug we rarely use, that is nicotinic acid derivative. This derivative inhibit hepatic triglyceride production and VLDL secretion, which leads to reduction in the LDL and increasing HDL. This sometimes leads to flushing, palpitation and GI disturbances. So actually this is all, but this topic may be boring because max of the term you are aligned, I think. Okay, So when you will cover the pathology and pharmacology part, you will understand better. Okay. Any questions up to this? You can ask. কোনো কিছু বুঝতে অসুবিধা হচ্ছে নাকি কিছুই বুঝতে পারলে না? কিছুই বুঝতে পারলে না? See, this is very difficult before, this is very difficult to understand the medicine classes before covering this pathology and actually pharmacology classes, okay? You will understand gradually. There is a last slide, this one. See, this is the treatment algorithm. I don't know what extent you will understand. Statin are used in primary prevention. This can be used in men more than 40 to 70 years and women more than 50 to 75 years. We have to calculate the ASCVD risk, that is atherosclerotic cardiovascular risk. If the risk is less than 10%, we advise the patient for a healthy lifestyle. We do not start any statin and febric acid. And if the risk is 10 to 19%, we start moderate intensity statin, and if risk is more than 20%, we can start high intensity statin. Statin are mainly used atorvastatin, rosuvastatin and pravastatin. Atorvastatin is low intensity is 5 mg, moderate intensity is 10 to 20 mg and high intensity is 40 to 80 mg. Pravastatin we can use 10 to 20 mg and moderate intensity 40 to 80 mg. Rosuvastatin low intensity 2.5 and moderate intensity 5 to 10. So what actually we do in case of more than 40 years of age in case of male, and in female, if patient is more than 50 years age, we calculate the ASCVD risk. ASCVD risk calculator involves lots of factors that includes age, blood pressure, dyslipidemia status and diabetic status. After calculating the risk, if the risk is less than 10%, we advise the patient for lifestyle modification. If it is between 10 to 20%, we start moderate intensity hypolipidemic drug, that is statin, and if risk is more than 20%, we can use high intensity statin, that is atorvastatin or rosuvastatin.